Welcome everyone to the final session of this conference. I'm Zoha Waqar. I'm the Program Manager of Health Research at CERP. Over the past 3 days, we've had the privilege of engaging in thought-provoking, informative, and deeply insightful discussions. And today, through this panel session, we hope to close on an equally important note, one that not only reflects on the research and evidence we've explored, but also pushes us to think deeper about how this knowledge can be translated into actionable policy outcomes. The real test of these ideas we've debated lies in their ability to generate momentum and create appetite among key policy actors in the country for sustainable change. Today, we have a distinguished list of panelists who are joining us and who bring a unique perspective to the conversation. I will just quickly give a review of the structure. So we have four panelists joining in, and we will each allocate 15 minutes to each speaker, and then have a 15 minutes Q&A session at the end. I will first introduce the panelists, and then we can start with opening remarks. So we have Maroof Syed, who will be presenting opening remarks. He is the president and CEO of the Center for Economic Research in Pakistan. He has over 28 years of entrepreneurship, investment, and leadership experience across multiple sectors. He has held senior management positions at various large and startup technology companies. He co-founded Carnival Group, which invested in late-stage technology startup companies, including Tesla, Twitter, Facebook, etc. He currently serves on the board of directors of the Pakistan Innovation Foundation and the Public Interest Law Association of Pakistan. Welcome, Maroof. We also have Zeina Sifri, who is the senior program officer on the maternal, newborn, and child nutrition and health team at the Gates Foundation, which she joined in June 2020. Within the team, her focus areas include maternal nutrition, where she works with governments, donors, and implementing partners to support the scale-up of multiple micronutrient supplements for pregnant women. Her work also includes strengthening healthcare systems in Pakistan within production of innovative maternal and newborn health innovations while leveraging social protection platforms for health and nutrition. She has lived in Africa and Asia, and for the past 20 plus years has been working with governments and partners on translating evidence into action, particularly for women and children. Welcome, Zeina. We also have Dr. Qurat, who has joined us from the UNICEF Punjab office today. She has more than 28 years of work experience in health, including clinical as well as primary healthcare management, maternal child health, nutrition, and immunization. She works closely with the Department of Health and other development partners in Pakistan. Has been with UNICEF for the last 15 years, during which she has served not only in UNICEF Pakistan, but also in Tunisia and Libya. She started her career as a pediatrician in the Mayo Hospital and the Children's Hospital. We're very excited to have you here. Then we also have Dr. Mirza. Mirza is an associate professor at Lahore University of Management Science, Department of Life Sciences. Dr. Mirza received her PhD from University of Alabama in molecular microbiology. In the past, Dr. Mirza has worked at London School of Tropical Medicine, London and National Institute of Human Health and Hydration in Netherlands. She works at the intersection of infectious and communicable diseases, investigating immune responses to pneumococcal vaccines in children and elderly with type 2 diabetes. Her lab provided the first evidence on immune response to pneumococcal vaccines in those with type 2 diabetes. She also serves as a research fellow at the Center for Economic Research in Pakistan. Thank you, Dr. Shaper, for joining us today. We also have Dr. Jishnu Das, who has joined us online. Thank you, Jishnu, for waking up really early on a Saturday morning and for your presence in this panel today. Jishnu is a professor of public policy at Georgetown University. His research focuses on healthcare in low and middle income countries, with work spanning quality of care evaluations, provider training programs, and the design of India's federal health insurance scheme, which reached 150 million people. He has advised governments during the COVID-19 pandemic, served on the Lancet Commission on COVID in India, and continues to shape global debates on health systems and service delivery through applied empirical research. Jishnu also served as the lead economist in the Development Research Group at World Bank, and he also serves as a PI on CERP's flagship Education Leaps program. Thank you, Jishnu, for joining us. Now I would request Maroof to please come forward and deliver some opening remarks. Thank you.
All right. So I think I have the easiest job at hand, which is just to introduce, share a few remarks. But let me start by first congratulating you to making it to the last panel of the day and the last panel of the conference. And I think it's really appropriate, given our proclivity for hybrid power structures, that this panel is hybrid. Somebody's online and we have a few people here. We can laugh at that. It's okay. Nobody's recording. So anyway, so I think I will make three broad points. And then I think the real reason we're assembled here is to actually hear from the panelists and give you the opportunity for questions. So three main points are going to be around, Ali this morning in the panel talked about that it's not just unfairness of taxes, but unfairness on the public spending side, right? And, it also reveals something else. It reveals our preferences and our priorities as a nation. How could we even expect to grow as a country, as an economy, if we spend so little on human capital, right? Especially given very deep intersectionality between health and education. The second point, I think it's very evident given the floods around us. So many people, millions of people displaced currently. And, that the climate shocks are now no more discrete events that are happening in Pakistan. This is the new equilibrium. This is the new reality. And, if you just go by 2002 floods, there were, roughly 650,000 women, pregnant women in flood-affected areas, with roughly 75,000 births in the first month of that flood, right? So you can rebuild roads. It's hard to rebuild people. And once you've lost that space and time to have the right nutrition and so on, it's hard to recover. And that has, I think, should make our priorities come in line with the reality. The last one is really, we've been talking a lot, and I think Zoha alluded to this nicely, which is we've been talking a lot about evidence. And of course, evidence generation is very central to understanding problems and understanding what eventually will work. But it is also, we've been acknowledging the fact that we have to bridge this gap between evidence and practice. And at CERP, we have kind of internalized this quite a bit. There are a lot of frictions when you try to do that. And health is a good example of our work actually happening across all 6 verticals at CERP, right? So in evidence generation, you have examples like infant feeding, where we're looking at information barriers for women. But then we're also on analytics with the partnership with Gates Foundation and Mathematica, really looked at like a pricing study as to when you take out subsidy, when you take out this support, what is acceptable in the market. Doing hepatitis analysis for the government, and now most recently announcing a partnership with the government of Sindh on use of AI for early detection of pregnancy issues in women. So, and then survey, we are doing flood reconstruction surveys right now, and especially given the current situation, we are actually changing the questionnaire a little bit to collect more pertinent information. And lastly, which is very important for this panel to unpack as well, is really thinking about policy. And I think COVID gave us a really good opportunity because there was such high level of uncertainty that I think there was an opening to actually think about how to systematically do policy interventions that are data driven, right? And I often give this analogy that it's kind of like being in a mountainous area and you suddenly see fog. So what do? You don't press on the accelerator and hope the road is going straight, right? You slow down. You slow down and take in the environment. And that's all data collection really is, that you are accessing or collecting new information to make the right decisions, right? So go slow to go fast, right? And I think that our work on smart containment with active learning gave us that opportunity to really deploy evidence and make it more palatable on the policy side and ensure that we can help the government or policy actors throughout that policy process. With that, I'll give it back to Zoha and start with the panel. Thank you.
Thank you, Maroof. So I think thank you for setting the stage so powerfully. We'll now turn to today's panel. I'd like to start with Zeina to shed some light on the Gates Foundation perspective. So I think from a donor lens, just to sort of dig deeper into the maternal and child health domain, what do you think, given your experience and Gates' work in Pakistan, what kind of interventions have shown the most promise for scalability and sustainability? Maybe if you could shed light using some examples.
Thank you. Thank you for having me on this panel and for this important question. The Gates Foundation is very happy to be engaged within Pakistan. There's so much momentum, there's so much leadership when we look at the different government entities that work on health, but also some of the private sector actors. And we have a lot of good partners that are taking on some challenging activities that we are proposing, and trying to figure out how these can be scaled and how these can be adopted. There is no doubt that maternal health is a key issue when it comes to Pakistan. Unfortunately, you have some of the highest maternal mortality rates. Same for neonatal mortality rate. It is the highest that you have in Pakistan. And so we're really trying to jointly with the government and key implementing partners try to figure out what are some innovative ways that we can have a major impact on these numbers. So within the context of that discussion, or those discussions, we have been talking about the importance of nutrition when it comes to maternal health, and also for newborn health, also for human capital development. The link is directly there. We know that Pakistan has a huge stunting problem. You have a stunting rate of about 40% across the country. Nationally, there's fluctuations, of course, within provinces and also within districts. But when you try to make an impact on a population where you have such high stunting rates, you really need to go back to the basics. And that is with conception. So when we're talking about having an impact on stunting, we talk about maternal nutrition. You want the woman ideally coming into the pregnancy to be well nourished, but if not, then during the pregnancy to have access to highly nutritious foods. One such intervention that has been proven to have a much higher impact on birth outcomes is multiple micronutrient supplements. So traditional standard of care for pregnant women is iron folic acid. But if you go to some of the more developed countries, you notice that very few doctors and midwives would prescribe iron folic acid, rather they provide multiple micronutrient supplements. To that end, UNICEF, the World Health Organization, and United Nations University developed what could be an ideal formulation of a mix of micronutrients, 15 micronutrients to be precise. It's called the UNIMAP formulation of these multiple micronutrient supplements. Many studies have been done. There's about 19 clinical trials, a meta-analysis, and a Cochrane review that has been done. And they have shown the superiority of MMS as compared to IFA when given to pregnant women. And those impacts are on birth outcomes, such as small for gestational age, low birth weight, prematurity, all of which are precursors to further health problems when it comes to a child growing up. So whether the child is having a ability to thrive, to go to their full potential or not, is determined in part by how they are born and their state at birth. Beyond that impact of MMS on birth outcomes, you notice that the birth outcome impact is even higher if the woman is pregnant or if the woman is, if the woman is pregnant. I think I was a bit distracted. If the woman is undernourished or anemic, and there the impact is even higher, triple sometimes. So that's one key intervention that we are supporting the government of Pakistan to scale up, because it's such a proven intervention. And there's a lot of interest both from the government but also from the private sector, with pharmaceutical companies that are interested in manufacturing it locally, which makes it then easier for the government to take it up if they can procure it locally. Another intervention that we're very excited about that has the potential to have a big impact, and that's building on work that we've done at the primary healthcare level, trying to understand what is the access to ultrasounds for pregnant women. We realize that there's often a situation where perhaps there is an ultrasound machine, but maybe it's not functional, or the person who is responsible for the ultrasound machine, the sonographer, is only there from a certain time of the day to a certain time of the day. So then you have times where the machine is there, but there's nobody to use it who's qualified. And so in those instances, what we're trying to start introducing, and you alluded to that already, is an AI-enabled ultrasound. So it's a point-of-care ultrasound that is basically the probe attached to either a cell phone or to a tablet. And with that, you have an AI algorithm that is embedded that helps a highly qualified person be able to interpret the results. And so it doesn't replace a real ultrasound, but it's a bit of a screening tool. It's a quick sweep. It takes 3 vertical sweeps, 3 horizontal sweeps. You get a reading within a minute or 2, and it tells you whether this is a high-risk pregnancy or a normal pregnancy. And it can help the healthcare provider make the decision of whether this woman should be delivering in a BHU, for example, or should go to a higher level facility. I'll stop here because that's already quite a bit of information.
Thank you so much. So I'll just ask 2 follow-up questions. I think one first related to the MMS that you mentioned. So given that, like you mentioned, anemia, I think if I remember correctly, it affects around like 47% of women in Pakistan of reproductive age. So given the importance of iron and folic acid, especially during pregnancy, and at a time where we see that, aid in general, particularly for health, is globally shrinking, and, there are fluctuations at the donor level as well to support countries to provide these supplementation and, other sort of interventions. What would you say about how receptive governments are to, indigenize production of such supplements? And secondly, I think to your other comment about AI-enabled ultrasounds, I know that that's a new project that Gates is doing with CERP as well. But how is the government responding, and are we seeing any positive reactions? I think it's too soon to talk about scalability, but if you could shed some thoughts on it.
Absolutely, thank you. So on MMS, there's across the world where we're working with governments who are interested in MMS scale-up, they are often very interested to have that product be produced in country. In the case of Pakistan, that is actually one approach that we are pursuing. Not every country can have MMS manufacturers. It's a very complex product to produce. If you think about it, the Panadol or the aspirin that you take is one active ingredient. In MMS, you have 15 active ingredients. So they interact, they degrade each other, and once you press them into a tablet, those interactions are accelerated and the degradation can happen even faster. In addition, we are working with UNICEF to have this product be pharma grade, which is a higher level of quality. And with all that in mind, there's challenges for good manufacturers only to be able to resolve. And so within the context of Pakistan, the government is interested in taking up this approach. The Ministry of Health at the federal level has put MMS on the essential medicines list. So it's now a product that is recognized as an essential medicine within the context of Pakistan. But also there was a directive coming from the federal ministry to the departments of health at the provincial level requesting that they switch the standard of care for pregnant women from IFA to MMS. So there's internalization at the level of the government of Pakistan, and now we're working with manufacturers, also at the request of the government, to try to see what could be potential opportunities for local manufacturing, with the understanding that we're not talking only about the local market, which is about 6 million pregnancies per year, but we're also talking about export opportunities through UNICEF that does tenders for qualified manufacturers. So the Gates Foundation is working with a certain number of manufacturers within Pakistan to try to provide some technical assistance to get them through the R&D where they're developing the actual formulation based on the UNIMAP technical specifications, but also to try to help them through all of the audit process that they will have to go through to get to UNICEF qualification and also United States Pharmacopoeia verification. Either one would work, and we're supporting them to go through that. There's also some financing opportunities that are available to help manufacturers de-risk some of these investments for themselves. On the AI ultrasounds piece, there's actually quite a bit of interest coming from both the federal and the provincial level. It's a bit of we have to use a bit of a stage gate approach because it's still a sort of novel product that's being tested. We're trying to get FDA approval, but there's definitely a lot of interest, especially in instances where you have facilities that don't have an ultrasound machine at all. And then in those cases, it's an easy step to get to an AI-enabled ultrasound rather than investing in a big machine and trying to have the qualified staff to use it.
Sounds good. Thank you. Okay, I think that's a good segue to move to Dr. Kurtilan. And maybe, if you can also shed some light from the UNICEF Pakistan perspective, and especially as a health team lead in Punjab, if you can maybe talk about some of the most effective UNICEF-supported interventions for maternal child health, particularly at the facility and community level. And I think one area which is of personal interest as well to maybe comment on, given the increased push towards digitization, how what is your experience of how prepared our health workers are and to not only adopt, but to also adapt to digital tools and to, AI-enabled interventions in the future?
Bismillahirrahmanirrahim. Thank you, Zoha, for providing me this opportunity of being part of the panel. And I can see diversity in the audience also, and I hope that I'm also going to learn from you also. And Zeina, it was very, enlightening to hear from you, because UNICEF is also partnering with Gates Foundation on nutrition. But here I will only talk about MNCH. UNICEF is, as you know, we are UN, we are not the donors. And we are working very closely with Department of Health for improvement of maternal, newborn and child health. And especially our niche is the newborn health and immunization. And we are working on the continuum of care from the community to the facility level, and starting from the adolescent girl to the mother and then coming to the newborn. Over the last more than a decade, UNICEF has introduced very cost-effective, evidence-driven and internationally accepted practices in the country for the survival of the newborn. For example, the newborn resuscitation, essential newborn care, kangaroo mother care, treatment of small and sick newborn care, then application of chlorhexidine for the cord care. All these interventions, they are very less costing, but they are very cost effective. They were not initially in the country, and UNICEF is the one which introduced it. And from the community level to the facility level, capacity building was given to the staff in the community as well as in the facility. And over the time, these interventions, they have been then scaled up by the government, or they are being scaled up at the moment. For example, chlorhexidine for cord care was started in 2 districts, and now it is being implemented in all the Punjab. Likewise, kangaroo mother care was initiated only in 1 center in Punjab, and now it is being practices all over the country. So that's a big success. And the data also shows, the mixed data and the DHIS data shows that these interventions have contributed in the reduction of the newborn mortality in the country, and especially in Punjab. though our numbers are still high, our percentages are still high, we need to maintain the momentum, and we need to, focus also more on the quality. Now, if you talk about the data and the digitization, over the past few years, a lot of use of data apps and data tools has happened, and the workers in the community as well as in the facilities, doctors, nurses, all, they are using the tools. However, they are not linked with the quality of the service provision. Those data tools, they may register the number of clients, the OPD, for example, how much was the OPD, or about the attendance of the service provider. But there are certain interventions which definitely need an interaction, face-to-face interaction. For example, you may have some digital app or a very good video about how to resuscitate the child. But unless you develop your skills, hands-on skills for resuscitation, you cannot achieve the goal. Likewise, if a video on breastfeeding, a very good video can support a lot. However, a healthcare worker has to be well equipped on how to, exactly support the mother in the correct position and how to initiate that. So, in my opinion, a blended kind of approach is required, especially for the capacity building of the care providers, even in the facilities or in the communities. And it can be some very good digitized tool, or the videos, or some online courses, but the face-to-face component has to be embedded into that. Then we can, achieve the desired outcome. Thank you so much.
Right. So just to follow up to that comment, I think, what would you say in your experience, like what kinds of support, whether that's training, providing better infrastructure, or, incentives maybe to these health workers that can sort of bring about the biggest difference for them to actually start using these digital tools? How can UNICEF and implementation partners really sort of provide support, given that we acknowledge their issues within the quality, when it comes to quality of the data that they're reporting? But what would you think are areas where support can really be provided at?
Okay, in my opinion, every area, every component which you mentioned has a role. It depends upon the intervention.
Right.
But definitely the capacity building of healthcare providers, it is an area which, and on the both, on the digital platforms also, and also on the face to face, that can play a big role. That can go a long way. And UNICEF is focusing a lot on that. We have had a lot of trainings for the healthcare providers, and not only the training, but initially the development of the curriculum also, standardized curriculum for that training, which is actually apt for that level of healthcare provider, be it the doctor or the nurse or the lady health worker or the lady health visitor. And since that curriculum has been developed with the consultation process of all the partners, WHO, WFP, Gates Foundation, all have been there. So it is one standardized curriculum which is being used. Then capacity building is one area. And the second area, which is very, very motivating for the healthcare worker, is a good supportive supervision and monitoring. I have seen in my personal experience that sometimes monetary incentives, they do not count a lot. But if you go to the health facility, you see the worker performing a good job, and you acknowledge that, that is a big motivation. So I think UNICEF partners and the government, they can all develop a good joint monitoring, supervision, evaluation framework. And to follow on that, we can also ensure the quality of the intervention also.
Right, right. Sounds good. And so I think particularly at the maybe basic health unit level, or like the work that these lady health workers do within their communities, do you think there's a role of factors like, cultural beliefs, gender roles, and just generally, I think, social norms that affect the take up of these digital tools as well? And maybe, what would you think are enablers or barriers within this social system that contributes to the take up, or maybe, the lack of it?
Actually, that is really a very, very important area. When we are talking about improving the quality of the service delivery, demand generation, and overcoming those taboos, those cultural belief is one of the important concern, again, of the government and also of the UNICEF and other partners, and a robust communication strategy focusing on all the tiers, from the policy makers to the healthcare providers to the communities to the beneficiaries. For example, if we are coming up with some program for the adolescent health, then taking those adolescents into account and talking to them and listening to their concerns, that also becomes important. And this is not only a one time process, you have to have a continuous advocacy on that. And it differs when you go to the community, your methodology differs, your methods differ, and your message is different. But however, when you go to the policy level, your messages are different. Right now, I will just give you one example, that UNICEF is working closely with the members of the assembly for just to introduce them with the kind of interventions which are in the province right now and which can contribute to the improvement of the maternal and newborn health. At that level, this is only fine that they are aware of that, and when at the time of the budgeting, then they can think of more budget allocations and that. But when we go to the community, we don't talk about these budgets and these level of things. We talk about the taboos, for example, around breastfeeding. We talk about the taboos around taking care of the child, and also the gender, when you have talked about the gender role. For example, especially in kangaroo mother care, it's not only the mother care, it's the involvement of the whole family, it's the involvement of the father. And when we want to reach the fathers, we reach the influentials of the community. We reach the religious leaders, they have an impact in the community. We reach the teachers. So, I mean to say that we have to reach the different tiers with different messages at different levels. Thank you.
Right, right. Yeah, I think that you're alluding to a very important aspect. I think at the community level, it's not just enabling technology for the health workers, but rather involving, given a patriarchal backdrop, involving the decision makers at the household level too. So maybe if you can, give examples, or like you mentioned, how are UNICEF interventions also sort of including those voices, or maybe targeting the decision makers who at the household level who are responsible for letting the women actually use this technology.
I can just give you one example, that the lady health workers, they move from house to house and they give messages to the women on the health, on nutrition, on hygiene. They have their tools, and they have a lot of material with them. UNICEF provided them with portable projectors. That is one of the use of the technology, that we provided them the portable projectors, and they were able to play some very useful and some very basic videos on how to take care of the newborn, or how to take care of the baby when the baby is low weight, or if the baby develops some signs or symptoms of illness, before taking to the hospital, what the mother can do. So these are very basic and small videos, and no hi-fi technology was required. The projectors were handheld portable, and you could just charge them like normal phone, and you could display them on the wall. And we have seen with our experience that those videos were very much liked by the women. They used to all sit together in groups. They used to watch those videos. Then they used to ask questions from the lady health worker about that video. And we have really seen, the success. And that was introduced in 2 to 3 districts. But then we, replicated in more districts. However, due to resource constraints, we were not able to, provide it in many. And there comes the role of other partners also, that we can leverage the resources, we can leverage the funds, and we can, cash on these proven interventions, and instead of duplicating something, or getting something which is not very standardized or not very proven.
Right, right. I think that makes me ask a follow-up question from both you and Zeina regarding, like, these interventions you've both mentioned, like that involve AI or the use of digital technologies. So when these interventions are actually scaled up into larger programs, there are challenges with maintaining implementation fidelity, which often emerge. So from your perspective, at both the program implementation as well as for Zeina at the donor level, how do you think about balancing this need for scale with ensuring that quality of these interventions can also be sustained?
May I answer first?
Sure.
Okay, I will just answer with one point that, in my opinion, when Pakistan has a large population, scaling up is not very, easy going to that number of people. The intervention is started at a small level, but scaling up is not easy. And then there comes the role of all the donors and partners to, leverage the resources and come up with some integrated approach and integrated messaging and integrated programming. And then when some program is started, initially it all starts well, but then gradually monitoring, supervision, accountability, it becomes weak. So I think at the start of the project, a very robust monitoring accountability mechanism, they are really important. And to take them also along the way, and to, and then also comes the role of the district authorities, provincial authorities, and the role of the regulatory bodies in the country and the province. Would you like to add?
Yeah, I think that you've answered it perfectly. I was going to say the same thing. So, first of all, it has to be led by the government. If this is not something that they are interested in scaling up, and you come in as a donor and you say, look, this is this great toy we have, we're going to help you, and then you disappear and they're not engaged, they don't have the ownership of it, it will not succeed. And the second thing around that is the monitoring system with a feedback loop, with supporting supervision to make sure that you catch any lapses early on. And so that these are the two sort of key pillars for it to succeed.
Right. And so, given your experience, what would you say are the biggest challenges that emerge, working with the provincial governments to implement such programs? We acknowledge that, these interventions rely a lot on political will. And a lot of these programs also sort of, get either transferred or discontinued when a new government comes in. So how do donors and other partners sort of maintain that momentum and sort of, support or encourage the governments to sort of sustain these interventions?
Well, these primary healthcare interventions and public interventions, they take a long time to show their results. They are
Right.
not visible, just like anything. If you build a building or you build some, hospital, it is visible. So most of the, trends become to have huge investments in that. So continuous advocacy with the department, with the authorities, that can play a role. And this is what we do, UNICEF and also the other partners, that continuous advocacy on that. And also then sometimes with the change of the governments, it becomes a challenge, but gradually, if we maintain the momentum, if we continue on that, then things are smoothed out. I can see that a few years ago, nutrition was not on the agenda. In the floods of 2010, then nutrition, it emerged as a huge emergency, and then nutrition strategy and programming, and it was all initiated by development partners. But definitely seeing the benefit of that, government did scale it up. And then the nutrition program was scaled up in the whole Punjab and also in other provinces. So I think continuous advocacy and sticking and maintaining the momentum and coming up with basic and you can say the proven interventions, that really helps.
Zeina, would you like to comment?
Sure. I'll give two examples to illustrate how this can be done. One is leveraging other platforms, so using integrated approaches. First, you take evidence-based interventions linked to nutrition, for example, and then in the case of Pakistan, we have the social protection program that is excellent, whether it's at the federal level or now more and more the provincial levels, and in Punjab and Sindh particularly. And then if you have those approaches, you can have sustainability. And we've seen that with the social protection program at the federal level. With the change of government, the program has stayed. It's just been evaluated yesterday. Aga Khan University presented results showing 20% stunting reduction with an intervention with the kids up to 6 months of age, which is significant and one of the best results we've seen in a very long time. So that's one way to approach it, integrate it in other programs. The other one is when it comes to financing, which is often the problem when you want to scale up with the governments thinking, how can we integrate this into our existing budgets? We have, in the case of the multiple micronutrient supplement, established a fund that is managed by UNICEF called the Child Nutrition Fund. The Child Nutrition Fund has a one-to-one match component. Any government who buys a bottle of MMS using their domestic resources will get a bottle free.
Right.
That helps governments plan in the longer term to see how they can leverage this fund to integrate this type of product and intervention into their system for it to become part of the regular budget and not part of a PC1 every time. So,
Right,
yeah.
right. Thank you so much. I will now move to Dr. Shaper to present, a more research and science perspective. So, Dr. Shaper, given your extensive research in the maternal child health area, what would you say are, community level interventions that have proved to be both cost effective and scalable, and also that sort of, are taking account of locally available materials and sort of able to incorporate local like practices. So maybe if you can talk a little about that.
Can everybody hear me? Oh, good. I think my husband is the only one who can't hear me. Everybody else can hear me. So, first of all, thank you for inviting me to such a diverse group of people. Usually, I'm just talking to 6 nerds who work in my lab or 8 nerds who work in the faculty. But it's a treat for me to be talking to so many people, and I hope what I say resonates with some of you and struck some chords among you. So, first of all, answering your question about the interventions, I think the best intervention that Pakistan had adopted so far for maternal and child health is the Lady Health Worker Program, because the women always wanted to be heard. And there was nobody. I mean, there are lots of broken women out there who wanted to talk, who wanted to discuss their problems, and there was nobody listening to those problems. And I think having somebody to listen to those problems actually made a huge difference. And every lady health worker is responsible for about 250 households, and they consider them their God. They're their guardian angels. And if a lady health worker come up with any kind of intervention, they are willing to try it. And that's, I think, most of these programs are leveraging the power of lady health workers. Now, coming to the MMS and other nutritional programs, we always talk about evidence base. And I'm not sure if we are talking about the biological evidence. We are detecting the need for it, but I don't know if we are going back and determining what kind of biological pathways will be affected by MMS or by other nutritional supplements, and how are they going to improve, like we still see stunting. I mean, I'm glad to hear that there's a 20% reduction in stunting in one of the AKU study, but I don't know how biologically that stunting is working. And if you look at some of the international data, Mexican Americans had worked on it like gazillion of years ago, and they identified this gene that's called the thrifty gene. And what thrifty gene does is that all those parents who had gone through multiple cycles of famine and festive or plenty of food, that thing starts to accumulate fat. So now that Mexican Americans are not undergoing any of those cycles, they are still accumulating fat. And there is a ton of obesity in Mexican Americans. And now they are trying to target the metabolic products of their gene in order to bring the obesity down. And the same is true for our population. I mean, coming to Pakistan, you have malnutrition is like a spectrum. So you go all the way from malnourished, like really severely malnourished, all the way to obesity. And obesity is definitely hidden hunger. But what are the biological basis of those? And is a child inheriting starvation from his mother, which is the transgenerational transfer of starvation. And I think I have talked about transgenerational transfer of or inheritance of starvation at so many forums that I'm turning blue. But still, I am not sure if people actually understand the importance of these things. People are now moving into that arena. So whenever MMS or any other nutritional supplement is given, people are looking at least microbiome. That is it impacting the microbiome? Because microbiome is turning into one of the major components of health and disease. So they are trying to see if microbiome is changing and if that change in microbiome is determining health. And how do they do that? Because your gut is really connected to your head. And whatever components the microbiome produce, whatever molecules you produce in your gut, they affect your appetite. And maybe that is the pathway, but nobody had worked on it. So when we come to evidence, I think just identifying the rates of disease should not be the only evidence. We need to have some biological evidence to back that disease, and then some biological evidence to show that improvement have been made. In terms of my research, so I work at an intersection of both the infectious and the chronic diseases. We see a lot of pneumonia. Yes, pneumococcal vaccine is reaching about 80% of children, at least in Punjab. I can't speak for Sindh. But even in Sindh, I think the immunization rates are pretty good, but you still see pneumonia. Then the other thing where kids are dying a lot is from neonatal sepsis. And for neonatal sepsis, we are looking at mothers who are colonized by group B strep, because group B strep is a very important bacteria that can cause neonatal sepsis. I mean, you can have early onset of neonatal sepsis, you can have late onset of neonatal sepsis, and all of these things are impacting child health. So it's not just nutrition that is impacting child health, but the exposure to these infections even before they were born. And most of these women, they don't even know their carriage status. They don't know how this carriage is going to impact the health of their child. And then even in stunting, I mean, we really need to understand the pathways that are impacting stunting in each individual, because these may be different depending on their ethnic background, depending on the nutritional status of their mother, and depending on the nutritional status of the child itself. So I think these are the few things that are kind of really important, but we seem to tend to ignore it.
Right. Thank you, Dr. Shipper. I think I would also like to learn about your work at the community level, and what have you observed, and maybe if you can talk a little about what locally available options exist to sort of provide greater nutrition for these mothers. What are some of the interventions that have worked in our local context? Maybe the recipes that have sort of been more effective.
Yes. So I don't directly work with nutrition, but I'm looking at the immune responses to vaccines. And immune responses to vaccines are very intimately tied to the nutritional status of the child. And unfortunately, although we are vaccinating a lot of children, but these kids are coming back with pneumonia. And the strains that are causing infection in these children are vaccine strains, which means that these kids keep getting infected by the same strain and they keep developing pneumonia. There are lots of biological and microbiological and molecular reasons for that, and I'm not going to go into that. But what I try to do is I try to encourage these mothers to use things that are readily available in the house, like cream of wheat. I mean, cream of wheat is something as so simple, and I think every household can afford to have cream of wheat. If you read some of Dr. Bhutta's paper, khichdi is one thing that he popularized for diarrhea. And WHO also talks about khichdi, and it's just simple gruel of rice and lentils. And instead of giving kids these acha mom or cham, I'm sure that they have some medical benefits as well. But if they can simply find things in their house, so maybe one of those interventions should be to use locally available ingredients and see if they can be converted into nutritional foods.
Absolutely. I think you talked about vaccines, and I would also like, to maybe speak a little about your work during COVID, and, the maybe if you can just maybe comment on how health systems you would say are prepared for these escalating and interlinked challenges that we've seen during COVID, and now we're seeing with different sort of climate shocks. So in the context of these outbreaks, what insights can you offer, and maybe how can Pakistan's health system adapt better and respond better to these kind of shocks?
Okay, so it's kind of a very strange situation. So Pakistan has very high levels. Pakistan ranks number one in diabetes. And diabetes is a precursor, or diabetes actually, people with diabetes are so fragile that they can get any kind of infection. I mean, wound infections are very common in diabetics. But if you have an epidemic like COVID, these are the people who are the first ones who will get affected. And infections or outcomes of infections in this group of population is very severe. So you really need to look out for them. But that's by the time you start looking out for them, it's already too late. So you have to keep an eye on, which means surveillance, on an infection or on emergence of an infection. So I also work with international surveillance network for pathogen, and they are now recommending water surveillance for everything. And I think that this is such a smart idea because even during COVID, water became the medium for transmission of infection and for surveillance. So people were looking for viral RNA in water, in sewage pumps to determine or to identify areas that were highly susceptible or that were high risk. And then this was called smart lockdown, that you identify those areas and then you implement lockdowns in those particular areas. So I think one, the power of working together, which is multidisciplinary research, and then two, identifying mediums that we can capitalize on for surveillance.
Right, absolutely. And I think just to sort of bring the conversation together, what would you say, what role can institutions like LUMS and CERP play to sort of get this kind of information across uh, to policymakers and to sort of bridge that gap between the scientific evidence that for instance, you're seeing from your lab results and really kind of get some change at the health systems level. And so it's institutions like LUMS where microbiologists are working, and then there are research institutions, there are non-profit organizations doing a lot of extensive work. But then are we really all speaking to each other or not? And what role can academic institutions like, LUMS play to sort of support that goal that we all have?
Yes, so speaking to each other, yes, maybe, but are we speaking enough? I don't know. And you see, LUMS, it has state-of-the-art facilities. I know it seems like a sentence from one of my grants, but today I'm using it in a different context. It does have state-of-the-art facilities. I mean, my lab is the only lab in Pakistan that had optimized the World Health Organization method for measuring the efficacy of pneumococcal vaccine. And then among us, we have people with AI. Dr. Maria Mustafa is sitting here. We have computational biologists. And I think these are the techniques that will help us understand spread of infection. It will also help us evaluate implementations and will also help us develop some modern methods for investigating infections. So yes, I think that different agencies should capitalize on it, and we must work with agencies like CERP or the government agencies. I mean, our lab collaborates very closely with CERP. We also collaborate with Expanded Program for Immunization. We are also collaborating with primary and secondary health. And what happens is evidence transfer, because we need to create this knowledge circle where we don't just keep evidence to ourselves, but we also inform the government, the other stakeholders of this evidence. And included in these stakeholders are communities. I mean, so many decisions are made for the communities, but communities are never involved in those decisions. Like you take these nutritional interventions to the communities, but they were never involved in it. They were never informed of it. You just take and deploy those, and it's important to do that because we can see that they are in desperate need of that. But at least involve them in these kind of decision making, and this can only happen if the communities, education institutes, and policymakers work together.
Thank you. Thank you so much, Dr. Shaper. Um, Now, I think we will turn to Jishnu, who's joined us online. Hi, Jishnu. Thank you for being patient and thank you for joining us today. So, I think just zooming out a bit and talking about what we can really do at the health systems level, and given much of your work has examined service delivery quality, what would you say that what is it at the primary health level that you see in terms of quality of care that really impacts maternal and child health outcomes in Pakistan?
So first of all, thank you for inviting me, and apologies I can't be there in person. It's term time, so it's very hard to travel. I really appreciated hearing all these wonderful, the very thoughtful comments that all of the participants made, and Shiber's point on epigenetics and how things transmit across generations is just so critical for us to understand. I just wanted to mention that again. Look, I'm an economist. I'm an empirical economist, and it's a little embarrassing for me that I haven't worked on health in Pakistan. Usually, I try and make sure I'm speaking only on topics that I have spent a lot of time working on. And my work in Pakistan has been on education, where we've been on it for 25 years now. So instead of saying things specifically about Pakistan, which the people on the panel are obviously much more qualified than I am to do. I thought I would take 5 minutes just to tell you a little bit about what the research overall on MCH from economics is telling us. And in doing so, I don't want to focus on small things, right? I don't want to focus on the specific program or the specific issue. I want to focus on what is the main message behind all this research, right? So इसमें, I'm going to start with a simple point, which is if you look at what kind of happened as the NDGs were coming closer, WHO sat down in Geneva and said, देखें, the fundamental issue, अगर आप एक graph बनाएंगे, you make a graph that says on the x-axis, we have fraction of women delivering in a facility. And on the y-axis, you have maternal mortality. And if you make that graph, it's very clear that where more women are delivering in a facility, the maternal mortality is lower, right? Now, based on that graph, what the WHO said and what a lot of countries said is we need to improve and increase facility deliveries, right? And one way that they said we need to increase facility deliveries is let's pay women to deliver in these facilities. So India started with a scheme in the state of Gujarat called the Chiranjeevi. And uske baad in 2004, we expanded that to something called the Janani Suraksha Yojana, which means the Safe Motherhood Program, right? And under these programs, women were being paid about 2,000 rupees to come and deliver in a facility. I wrote at that time something that said, are institutional births institutionalizing deaths? And one of the saddest, what I feel very sad about in my career is one thing was I should have pushed that more and more. Because look, the fundamental piece behind that was to say कि देखें, a mother who's choosing whether to deliver at home or to deliver in a facility, who's worried about, is my child going to live, is going to be swayed by 2,000 rupees. I mean, just think of that, right? Think about the fact that we are really saying कि women and men who each of us, many of us are fathers, many of us are mothers. The one thing we shut down our thinking on is thinking that a child may fall sick, right? I mean, that's like just the worst thing that can happen to you. अब आप मुझे कह रहे हो कि देखें, someone who is giving birth will be swayed by 2,000 rupees ki, if you give me this 2,000, I will go somewhere where my child can live. If you don't give me this 2,000, I will deliver at home where they may not, right? And what I want to talk about is so now what happened? So what happened was over time, institutional deliveries in India picked up, right? But here's the really sad story. Jahan par the capacity was okay. We found we found Marcos Vera Hernandez has a wonderful, very carefully done paper on this. He finds that there was no change in infant mortality, but where the capacity was low, as more women came into the facility, the crowding meant that more infant mortality actually increased, right? And it turns out that the same result has come out of Rwanda, the same result has come out from Malawi, that these conditional cash transfers had no impact. When you look at the causal impacts, they had zero impact on infant mortality. In India, millions of children have been killed because of this policy. So I want to go back and say, ki is policy mein, what was the fundamental driving force? The fundamental driving force is we didn't trust families. We didn't trust women. We can start from another place, which all the panelists have been doing, which is to say, why were women not delivering in these facilities to begin with? Right? And to do that, the point that's come up again and again is you have to start thinking about how are women being treated when they go into facilities, how are women being treated at childbirth. My friend Shohini Chattopadhyay, who's a fantastic journalist, wrote this very, very disturbing piece and a trigger warning here because, look, some of these are hard pieces to read, but until we read out these stories, we will not acknowledge the great difficulties and the great pains that women are actually going through when they deliver, right? So I'm going to read a paragraph from her work, which is very emphatically titled "I Can't Take It Anymore," right? And it really talks about one labor ward in the city of Calcutta in India. And let me just read you this one paragraph. The young, I can send it to you. It's Shohini Chattopadhyay, and it's called "I Can't Take It Anymore." It says the young doctor doesn't remember the first time he slapped someone in the labor room. Everyone slaps patients, all his MBBS classmates did, and the postgraduate students do too. It is almost a rite of passage. There was one guy, he was so shy, he never lost his cool. The day he slapped his first patient, that was an event. We made him treat us to biryani, he chuckles, right? And when you start looking at that, and when you start looking at, so that story started a bunch of work on abuse in the labor room. And then you look at WHO, there's a recent WHO surveys of 4 countries, right? 40% of women are verbally abused, 10% are physically abused in the labor room, right? To send a woman to deliver in a facility is not a trivial task. She knows there's half a chance she'll be shouted at, 1 in a 10 chance that she's going to be physically slapped. Okay. Then we turn around and say that the problem is the communities, the problem is these people don't understand. The problem is we don't understand. At a basic level, we don't understand that mothers, fathers are devastated when their children fall sick. If their children die, they're devastated beyond measure. Right? And there's this word trust, right? Itimad, right? I mean, at the end of the day, what all the studies are showing again and again is we need to have a level of trust in the people whose health we are trying to improve. And this is why I want to stress kind of two pieces. The Lady Health Worker program, everything that I've studied about it, it is a fantastic program precisely because these are women from the community who are talking and working with other women in the community in a relationship that they have had for ages and will have in the future. Right? I think that makes a huge difference, right? What's the other piece we are discovering? The other piece we are discovering, coming back to the idea of trust. There's a study that has come out recently that showed that if you give people money, just give them money, right? Infant mortality goes down 45%. Now, why does it go down? It goes down because it allows mothers who are pregnant in the 3 months before delivery to decrease their workload. It allows them not to have to worry about multiple things, and it allows them to visit and do their ANC visits with greater certainty, right? But again, the key part is not what does that matter. The key part, for me, is again, this is a fundamentally different way in thinking about how to help families and women who are struggling, right? It says, let's start from a point where we trust their decisions, right? It's not that they're going to have the medical knowledge, it's not that they're going to have everything. So, fine. I mean, these are things we always talk about. But fundamentally, let's trust their motivation ki I want my child to be healthy and survive, right? Then we can ask कि आपके सामने what are the constraints that you face, right? And it's not hard. I mean, again, in Shohini's article, when she goes towards the end, she goes to villages and she asks them कि आप facility में क्यों नहीं deliver करते, right? Why don't you do that? And every woman says, look, they treat us worse than we treat our animals, like the goats and the cows that they raise. Why would we ever go there? Right? That level of fundamental empathy, sympathy in a place where that is most needed is something we must bring to our work and something we must bring to the ideas of maternal and child health, right? So the other place I work, which is Meghalaya, is a small state in the northeast of India, and they have fundamentally shifted and changed maternal and child health because for every mother who dies, they do a full case study. Every mother who dies, right? They do a full audit report, right? A maternal audit for every mother who dies, right? And they find out what happened. And then they go back and ask not why didn't you do this, but why couldn't you do this? And then a lot of stories emerge. Look, I couldn't go there because there was a landslide and the road was closed. Right? And that starts to say, look, maybe we should have, and what they put in place, because so many where people were answering this in a hilly area, was they said, we'll put up a hostel next to a major hospital so you can come up to 2 weeks before. Right? And once you start changing your perspective and you say people are trying to do their best, but they need help at specific places, I think we emerge at a different place. So that's what I want to leave you with. I think that, look, the fundamental point here is let's move away from why didn't you do this to why couldn't you do this? And why couldn't you do this is a question that has at its basis a shared trust, right? A shared understanding that you are not somebody who is saying, oh, I don't care about the health of my child. The health of your child is for everybody. the single most important thing that we are willing to give up anything for, right? And that trust, that way of thinking just completely changes how we approach the problem and the solutions we come up with. So let me stop there, because it's an emotional plea, but surprisingly it is drawing from evidence that has been very clearly and carefully documented over the last 20 years, without making that basic point that what we are changing here is our trust in the people we are trying to help.
Thank you, Jishnu. Thank you so much for that point of reflection as well. Just a follow up, I think, thinking about your work in other countries and how that relates to the health system in Pakistan. And I think you mentioned both the conditional transfer as well as the unconditional transfer. So, this trust, I think, which is a very important thing that you mentioned, do you think maybe at when thinking about interventions that can work at the community level, is it really that maybe giving women cash transfers, like if they are unconditional, do they show more promise for women to actually you know have the ability or maybe give them the agency to take better decisions? I'm thinking about like a pregnant or a lactating women, instead of like evidence you pointed out to in cases where these are conditional cash transfers, and we've seen that in the context of Pakistan as well. There's a lot of work in Sindh where we're incentivizing women to show up for immunizations for their children, and they're being given mobile credits as an incentive. So is it really that maybe we think about a different way of incentivizing them, so that we can really sort of also empower them to make better choices for themselves?
So I think a couple of things I would be. So I think we have to be very careful about keeping things different, right? I think the big difference about labor and delivery is it's immediate. And remember that 80% of infant deaths happen within the first 48 hours, right? So it is immediate. Immunization is a very different ball game, because most people won't see benefits from immunization. Right? Now you do, of course, with 17 different vaccines, kuch na kuch you'll have staved off. But it's really hard to connect an immunization to a illness that was staved off, right? So I think we have to think about these two things very, very differently in the way we approach it. And I don't want to think about the unconditional cash transfers as incentives. It was just, here's money that, and BISP does this, here's money that allows you to not have to worry in this last 3-4 months of your pregnancy, right? And with that, people did various different things. So I don't think about it as incentive. I really think about it as a soft cushion on which you could structure the last 3-4 months of your experience. This study was done in Kenya, and people don't believe this, especially in Kenya, when I tell them. Kenya is another place where I worked a lot. People don't believe it in Kenya when I tell them that their medical care is much better than India's, which it is. And the key thing is that the top range of India is better, but the average in Kenya is much better, right? So I think we have to be really, really careful. And what I want to stress is, again, I think the work that was being talked about in the panel, of going to communities and understanding if something is not happening, why is it not happening? Just start with the approach that if something's not happening, let's try and understand the constraint, rather than think that it's people who do not know, right? How many times when we go to a doctor and we say, hey, what happened here? The first response will be, ye log to bilkul unpad hai. ये तो बहुत देर से आते हैं. These are people who are illiterate, they come too late, right? Why start with an assumption that the people we are trying to help are not trying to help themselves?
Absolutely.
Right? If we can just move away from that and say कि देखें आप नहीं आ पाए क्यों नहीं आ पाए, you will hear the stories. And once we hear those stories, we'll understand that in every community, every woman may have a different reason, right? A different constraint that stopped her. And our job is to start to understand how to lift those constraints. कहीं पर, it's turned out to be transport, right? कि मैं 2 दिन वहां बैठी रही, कुछ भी नहीं, बस नहीं मिली, ये नहीं मिली, वो नहीं मिली, right? Some places it's turned out to be that it's really hard to get to the city ahead of time. Right? मेरे रहने के लिए जगह नहीं है. Where will my relatives stay? They can't. Simply just having a room where relatives can actually cook turns out to be life changing. Right? Things like that. Right? Where are those conversations? Right? And I think everybody in the room knows that these conversations are critical. I just want to tell you that the evidence that these trusting people gives us great dividends is actually now very, very strong.
Right. Thank you so much. And I think we can close here, and I guess that's food for thought for everyone. And now I'll open the floor for question and answers. Maybe we can take 3 questions first and then have the panelists answer. Yeah, sure.
I am Mr. Ali from Nisar Medical University, Multan. I'm a clinical dietitian. Firstly, I really appreciate the efforts of UNICEF and Gates Foundation in maternal and newborn child nutrition. So, my emphasis is on nutrition education and assessment. In the general population, if we start from adult women, uh, most people wouldn't know that having a BMI greater than 20 is a necessity for the hormones to function properly. And likewise, in maternal nutrition and newborn care, there's a lack of nutrition education. The regular health visits are at the physician level, and those happen if some condition exists, like uh, the disease develops into a chronic condition or some acute condition, and there's no mechanism for general assessment, so we can identify some specific nutrient deficiency, like micronutrients and maybe protein deficiency too. So and even in all those programs and nutritional supplements are more focused on a holistic approach, focusing on providing a combination of nutrients. So I think there's a need of assessment of those specific nutrient deficiencies, and there's a need of nutrition education, knowing the basic facts and things that would help the population and mothers and newborn childs to be taken care of better. So, are there any interventions or programs that are working on those?
Okay, thank you. Can take another question, please. Just I'll request in the interest of time, let's be brief. You can state your name and affiliation. And then
So my name is Saleha. I'm currently working at this organization called PHC Global, which works at the intersection of various health programs. This was a very insightful discussion, first of all. My question is for Ma'am Qurat. I know that there is a lot of conversation surrounding the capacity building of frontline workers, if we take immunization, for example. But my question is, to what extent are frontline workers like vaccinators, for example, are they receptive to the idea of their trainings being digitalized? If you could give me some of your input on that.
this one.
Assalamu alaikum. I'm Mirza. I'm from CERP. First of all, thank you all the panelists for great insights. I'll just first make a quick observation and then two very specific questions. I think Zeina mentioned CNF. We did some previous work. You'll be surprised that only one government, at least a year and a half ago, it was government of Sindh, had actually submitted an application for matching, and they actually took advantage of CNF. Punjab was looking at it, but I'm not sure if they ever did it. So this is literally like money on the table that nobody wants to pick up. I mean, that's the status, on the ground for CNF. But I think in some way that ties into my comment, which is like, I think at the end of the day, we keep talking about 40% children stunted. And I think at the end of the day, there's no voice to the voiceless, right? How do we give the voice to the voiceless? And that's my first question, because to Dr. Qurat, you said that you need continuous advocacy, but thinking critically and taking inspiration from Jishnu here, who should be doing that advocacy and how is that happening and how do we increase that? That's first question. And the second question is to Zeina, who talked about instead of relying on PC1s for nutrition, this should really be integrated into regular health budget of the government where, whatever mechanisms you need to put in place for nutrition, they are put in place instead of relying on PC1s and ad hoc programming. So the question would be that given your work in multiple countries across the globe, what are some of the examples that have worked in convincing the government to actually increase the funding for nutrition? And are there any bright spots that you have seen and potentially one should look at for Pakistan also? Thank you.
Thank you. We'll just have the panelists answer these first round of. I think maybe Ms. Kurtalen, you can. This was a question around nutrition advocacy, and then another one related to nutrition education.
Well, for the first question about the nutrition education, you are actually very right, the need of the nutrition education. The lady health workers which we talked about, that is a cadre who has proved its effectiveness and its benefit in the community since 1997. And nutrition is one of the very, very basic curriculum part and which they have to deliver. We may question on the quality of the education, but that is the basic part of it and they are imparting that, one. Second is when the woman goes to the health facility or comes in contact with the skilled birth attendant for the antenatal care, nutrition education is one of the core component of the antenatal care, one of the 9 core components. Yes, again we can question about the quality of the antenatal care and if the components are not being done. And there comes the role of then monitoring, supportive supervision by the authorities at all the level. And there is a need to, improve upon that. But if we say that it is not there, that may not be very right. Right. And about the second question from the colleague from PHC Global on the capacity building, I would say that it is not only the digital platforms and the capacity building only through that. It has to be blended. And in my experience, when we have worked in UNICEF and we have supported a lot of trainings over the last few years for all the cadres, staff in the communities and also staff in the health facilities, doctors, nurses, vaccinators, lady health visitors, all of those people who come in contact with the newborn, with the child and with the mother. And we have seen that the blended approach is always working better. For example, again, I would repeat that you give a very good demonstration or a very good, video on the newborn resuscitation. But unless you show it in some clinical setting, that will not be lasting. And the hands-on skills, they are really very important. And secondly, again, the government right now is working on learning management information system. Many of the trainings are being blended into that. and that will be some like Agora's pattern or some trainings which can health worker can do in their community also. And but that will again be very good for a refresher point of view. For the first time training or for the induction training or for the starting training, it has to be some face to face interaction also and some blended approach. And later on, these digital tools can really help in imparting, the refreshers. This is my opinion.
Right.
Yeah.
Thank you. We can maybe turn to Zeina to answer.
Sure. Thank you. Imran, your question on the sustainable scale up or the budget recurring line. So you'll be very happy to know that the Child Nutrition Fund has been leveraged by the government of Pakistan for MMS. It's one of the first countries that has done that. And at the federal level, the Benazir Income Support Program has incorporated MMS into its budget for the National Noma program. And so they have already ordered almost 1 million bottles of MMS to be distributed through this conditional cash transfer program. This is in addition to Sindh, in addition to Punjab, and now KP is looking at integrating also MMS as part of a new social protection program that's going to be happening in South KP. So in terms of the longer term sustainability beyond this Child Nutrition Fund, one key possibility to get that done, to have it not only in PC1s but also in recurring budgets, is integrating nutrition, or in this case MMS, into some other health approaches. So for example, the essential health package that exists at the provincial level, once you get MMS into that, then you can make sure that it goes into the recurring budget. So that's work that we're currently doing right now with Sindh province, and hopefully Punjab will be next.
Thank you. We'll just take a few more questions.
Voiceless. That's 3 questions.
Okay. Next 3 questions, yes. Can we please have the mic here? This one.
Thank you. Great panel, great insights from everyone. My name is Maroof. I lead a development consulting firm called Globesite. And a lot of our work is at the intersection of policy and advocacy with, governments and other partners across the region. So one of the questions, we heard a lot about the Lady Health Worker Program and how it's been very effective in terms of reaching communities and listening to the mothers as well. So given, how that was affected by, devolution and transferring of, the program to the provinces, how can we prepare for more programs such as the BIS, cash transfers, everything, and more in government meetings at the federal level, we're hearing that, the provinces will be taking the lead, especially when it comes to health. How do we, as partners of a lot of the organizations who are working in this space, support provincial ownership of these maternal and child health interventions, particularly when it comes to the budget and as well as the political will allocation? Because we've seen in the case of the Lady Health Worker Program that it really went downhill. And now, as more and more programs will be, in the responsibility and the remit of the provinces, and then we've seen differential sort of responses from the different provinces as well. How can we, all of the people gathered here, particularly on the panel, support this sort of cohesive national sort of approach to it, despite the devolution and more responsibility being transferred to the provinces?
Right. Thank you. Can we please have the mic there? We'll also take another question. Please.
Hi, my name is Hasiburaman, and I'm a Statistics and Data Officer from Health and Population Department. I was interested in, we are talking about in maternal and child healthcare, but what about family planning? We are only talking about nutrition. So we have challenges into that as well, and government is also working on that. So, but I haven't heard about any research on that from the donor side or from CERP. So what's your take on that as well, please? Thank you.
Thank you. Any other questions? Okay. I think we can respond. So I think the first question open to anyone on the panel regarding provincial ownership. how can we support provinces to take better ownership of these programs? Jishnu, please feel free to jump in if you would like to respond as well.
I can start perhaps. It's a good question, Maroof. It's really a situation where you have to base it on evidence. You have to have the government at the provincial level take ownership. We know that devolutions happen. It's more or less applicable in depending on different contexts, but really having the involvement of the provinces from the beginning when you have, for example, I'll refer again to the National Noma program of the Benazir Income Support Program because it does integrate both health and social protection, and both are actually federal subjects, but you cannot be implementing that program in a successful way if you're not involving the provincial health authorities. And once they are convinced, it's something that they get more ready to take up themselves. So for me, it's data-driven. It has to be data-driven on that.
Right.
I'll make a comment.
Yeah.
I think sharing a different perspective, something that Shaper already sort of alluded to. I think one of the learnings that we had was during COVID. A lot of times there are many types of evidence, right? And as a policy actor, you're inundated constantly with evidence coming from this institution, that institution, and a lot of times these are very big silos. So not only is data in silos and fragmented in Pakistan, but a lot of the evidence that's hitting policy actors is in silos. So I think the multidisciplinary approach, and I mean, Shaper was, I'm gonna embarrass her a little bit, but she was the first non-economist CERP research fellow. And the reason was that immense contribution during our work in scale, where not having a microbiologist, there's no way a bunch of economists would have figured out that CT levels are different in kids that are coming oral pharyngeal versus nasopharyngeal. But the fact of the matter is that interdisciplinary approach and actually going to the benefit was we were going to the policy actor as a whole, as a big tent, not necessarily just one institution or that institution or one perspective versus the other. I think increasingly for these really complex issues, we have to take that multidisciplinary approach.
Right. I think there was just one last question. Maybe if you can quickly repeat.
Family planning, like module and pocket. I mean, I'm sure there must be some research on that. I was wondering if they can share some insights, like what are the challenges into that. So, like, I'm from the policy side as well, from the health and population department. So it's directly related to maternal and child health care. So, but nobody talked about it.
Okay. Maybe Ms. Qurat, would you like to comment?
Well, when we, talk about all the interventions of maternal newborn child health or nutrition or anything, when it comes to resources, and we know that the country like us, the population of even the country, and even if we say Punjab is like the population is that if it was a separate country, it would be fifth or sixth another country. We are, as UNICEF, we are part of all the technical discussions when it happens on family planning. But it is not direct UNICEF's mandate. The UNFPA is talking about it. They work on that. That's why maybe I did not talk about it directly. So maybe somebody from UNFPA or again from Department of Health and Population, they would be better able to comment on that rather than me.
Right. Thank you. I think with that we can close the session. I guess just two very important takeaways that I would highlight, which have emerged as part of discussions. I think first, thinking about the trust that I think Jishnu very beautifully and emotionally made us think about when we're doing all of these interventions within local communities and actually engaging the right kind of actors so that they feel that there is ownership when we want to scale up or think about making these sustainable choices for them. So incorporating that voice into our research, into our policy implications, etc. And then secondly, I think for all actors to work together to think about more multidisciplinary approaches to making sure that the research really from, at the laboratory level is reaching the communities through all of the actors involved. So thank you so much for being here, I guess, for that we end the conference.